In most medical dramas, the danger is loud. It's this sudden heart attack, the car crash, the monitor just flatlining. It screams for attention.
Right.
But today, we are unpacking a case that is, I think, terrifying, specifically because of how quiet it is. It's a story about a 65-year-old farmer, a man named Ravi, and a killer that started as just a tiny, painless spot inside his cheek.
And it's that silence that traps people. We're looking at a case of Buccal carcinoma cancer of the cheek lining. And Ravi's story is, it's almost a perfect archetypal presentation of this disease.
How so?
It starts with something so mundane, so seemingly harmless that 99% of us would probably just ignore it until it was way too late.
That's the real hook for me in this deep dive. We've got this detailed clinical file on Ravi. He's a farmer, lives a pretty routine life.
Great.
And he finds this ulcer. It's small, maybe a centimeter.
And it doesn't hurt.
It doesn't hurt. It doesn't bleed. It's just there. And because it doesn't hurt, he assumes it's nothing.
Which is the first and maybe the most dangerous misconception about oral cancer. We associate pain with danger. If it hurts, we go to the doctor.
Of course.
But early carcinoma is often completely painless. By the time this little sore forced Ravi to see a specialist 4 months later, the whole situation had changed drastically.
Right, the timeline in the file is startling. 4 months. That's not a long time.
No.
But in Ravi's mouth, it was an eternity. The ulcer just exploded inside.
It tripled. It went from a 1 by 1 centimeter lesion to this massive ulcerative growth involving a huge chunk of his cheek. In oncology, velocity is a major, major red flag.
The speed of it.
The speed. Rapid progression like that tells you the biology of the tumor is aggressive. This isn't some slow-growing cyst that takes years to change. This is a wildfire.
So let's get into the detective work here. The doctors sit Ravi down. They start asking him questions. And some of these questions, looking at the transcript, they seem completely disconnected from a sore in the mouth. For instance, they ask him if his ear hurts.
Yeah, it does seem odd, doesn't it? Doc, my cheek has a hole in it, and the doctor asks, so how's your ear?
Exactly.
But it's a brilliant piece of anatomical deduction. It's called referred pain.
So the wiring gets crossed somewhere.
Perfectly put. The sensory nerves in your cheek and your ear, they share a common pathway. It's the trigeminal nerve.
Ah.
So if the cancer is growing deep enough to irritate the nerve branches in the jaw, the brain gets confused. It projects that pain signal back up to the ear.
So if a patient comes in with a mouth ulcer and a totally healthy-looking ear that just aches, that's not a coincidence.
That's a siren. It suggests the cancer is spreading along the nerve pathways. It changes the staging and the severity right away.
Speaking of severity, the pain timeline for Ravi was interesting. Painless at first, like we said, but in the last 2 months, it became agonizing. Does that just mean the tumor finally hit a nerve?
It means it hit something structural. The lining of your cheek, the epithelium, it doesn't really have pain receptors on the surface, but underneath that, you've got muscle, you've got nerves, and you have the periosteum, that sensitive skin wrapping the jawbone.
Okay.
When Ravi started feeling pain, it meant the tumor had stopped just growing out into the mouth and started digging down.
It's digging its roots in.
It is. Or it's something called paraneural invasion, which is as nasty as it sounds. The cancer cells literally wrap around and infiltrate the nerves. Or, maybe the tumor just grew so fast the center of it died.
Necrosis.
Necrosis, yeah. And it got infected. And that infection causes inflammation, and inflammation hurts.
The doctors also checked for trismus. I remember reading that term. It basically means lockjaw.
Inability to open the mouth fully, yes. And this is a critical test. If you ask Ravi to open his mouth and he can only get it, say, a centimeter open.
What does that tell you?
It tells you the cancer has invaded the muscles of mastication, the actual motors that move your jaw. It effectively welds the mechanism shut.
Fortunately for Ravi, he could still open his mouth.
Yeah.
So the motor wasn't broken. Not yet.
Right. But he did have halitosis.
Bad breath. Which, given he has a rotting ulcer in his mouth, seems kind of expected.
It is, but it's specific. It's the smell of necrosis. It's anaerobic bacteria feasting on dead tissue and releasing sulfur compounds. It's a very distinct, unpleasant smell that an experienced clinician recognizes immediately.
The scent of advanced disease.
Exactly.
Okay, I want to pivot to the why. We've established Ravi is in trouble. But how did he get here? His habits section of the chart is, well, it's heavy.
It's a perfect storm. Ravi has been a beady smoker for 40 years.
Those are the unfiltered, hand-rolled cigarettes.
And he's been a quid chewer for 45 years.
And he keeps the quid, this mix of tobacco and nut tucked in his right cheek, exactly where the cancer showed up.
It's site-specific exposure. He has been physically placing a little carcinogen packet against that specific patch of cells every day for 4.5 decades.
But there was something in the source material about the combination of his habits that really caught my eye. Ravi also drinks alcohol, and the source called alcohol a solvent.
This is one of those aha moments in cancer biology. We usually think of alcohol as just another toxin to pile on, but chemically its role here is much more sinister.
How so?
Think of the lining of your mouth, the mucosa, as a shield. It's designed to keep things out. Alcohol is a solvent. It dissolves lipids. It thins that barrier and increases the permeability of the whole tissue.
So the alcohol strips away the armor plating.
Exactly. It opens the gates. And once those gates are open, the carcinogens from the tobacco, these things called nitrosamines, can walk right in and get deep into the basal cells where all the DNA replication happens.
That is just a terrifyingly efficient system. The alcohol unlocks the door, and the tobacco walks in to burn the house down.
It's a synergistic effect. It's why people who smoke and drink have a risk of oral cancer that isn't just added together. It's multiplied.
I want to drill down on the quid itself. It's got a reconite in it. And the chemistry you described in the notes, it sounded almost like an industrial process happening inside someone's cheek. Something about copper.
It is disturbingly close to an industrial process. Arecanut is naturally very high in copper, so when you chew it constantly, the copper levels in that local tissue just skyrocket.
Okay.
Now, biologically, copper supercharges an enzyme called lysyl oxidase.
And what does that do?
Its job is to cross-link collagen fibers. Collagen is the scaffolding of your tissue. Normally, it's flexible, but when lysyl oxidase goes into overdrive, it creates way too many crosslinks. It makes the collagen dense, stiff, and fibrous.
The source compared it to turning it into leather.
It's the biological equivalent of tanning leather. The cheek lining loses all its elasticity. It becomes stiff, it becomes white. We call this oral submucous fibrosis. The patient literally can't open their mouth because their cheek has turned into a sheet of leather.
And that leather is where the cancer starts.
That stiff, scarred, blood-deprived tissue is incredibly unstable. The cells are under constant stress. It's a breeding ground for malignancy.
So this wasn't just bad luck for Ravi. It was a chemical assembly line running in his cheek for decades.
It's chemistry, not chance.
Let's move to the physical exam. The doctors look into Ravi's mouth, and they describe the tumor as an ulceroproliferative growth. But the key thing they're looking for is the edge.
The edge tells a whole story. If you're a medical student, this is day one stuff. You look at the margin of the ulcer. A benign ulcer, like a canker sore, usually has a sloping edge.
Like a gentle beach leading into the water.
Good analogy. But a cancer, it has an inverted or rolled edge. Imagine a volcano crater. The rim is raised, thickened, and rolled outward.
Why does it do that? What causes that shape?
It's the growth rate. The cancer cells at the very edge are alive and multiplying like crazy, piling up.
Yeah.
That creates the raised rim. But the center of the tumor has grown so fast that it's outstripped its own blood supply, so the center dies and collapses.
A ring of aggressive life surrounding a core of death.
It's the classic hallmark of squamous cell carcinoma. If you see that, you don't need a crystal ball. You need a biopsy.
The doctors also felt the cheek. They use this word. Induration. hardness.
Yes. And induration is the firmness you feel that extends beyond the visible sore. This is the iceberg concept. You might see a 2-centimeter hole, but when you pinch the cheek, you feel a hard disc that's maybe 3 or 4 centimeters wide.
So the visible part is just the tip.
Correct. The base is what you feel. The floor is what you see. And for a surgeon, the base is what matters. That hardness tells you how far the cancer has really spread under the surface. If you only cut out what you can see, you're leaving half the tumor behind.
This brings us to a concept in the source material that I found pretty profound and honestly a little scary. Field cancerization.
This idea fundamentally changed how we treat head and neck cancer.
The way I understood it is, it's not just that Ravi has one weed in his garden. It's that the soil of the entire garden is poisoned.
That is the perfect analogy. Ravi inhaled smoke and bathed his mouth in tobacco juice for decades. That exposure didn't just stop at the border of the tumor.
Right.
His entire upper aerodigestive tract, the lining of his mouth, his throat, his esophagus, has been exposed to the same carcinogens.
So even the tissue that looks totally normal isn't?
Genetically, it's distinct. It's often called condemned mucosa. It looks normal to the naked eye, but on a molecular level, the DNA repair mechanisms might be broken. It's primed to turn into cancer.
Which explains why these patients often get a second cancer later on. The source used the terms synchronous and metachronous.
Right. A synchronous tumor is a second cancer we find at the same time. A metachronous tumor is one that appears later, maybe 2 years after Ravi is cured. He develops a brand new cancer on his tongue.
And that's not the old cancer coming back.
No, that's the scary part. It's a brand new primary cancer. It's a new fire starting the same dry forest.
That just shifts the whole perspective from fixing a problem to managing a permanent risk.
It forces lifelong surveillance. You can never say you're done. You have to watch the field forever.
All right, so let's get Ravi to the operating room. He's diagnosed, he's staged. The file says T2N00.
Which is a pretty standard presentation. T2 means the tumor is medium-sized, 2 to 4 centimeters. N0 means the doctors can't feel any enlarged lymph nodes in his neck.
And M0.
M0 means it hasn't spread to distant organs like the lungs.
So T2N0M0 sounds like they caught it in a decent spot. Big enough to be obvious, but before it spread everywhere.
Exactly. It's curable, but it requires aggressive intervention.
The plan is a wide local excision. But looking at the surgical notes, they take a lot more than just the tumor.
You have to. You need a margin. Usually we take about 1 centimeter of healthy, normal-looking tissue all the way around the tumor. Remember the induration, those microscopic fingers of cancer. The margin is your insurance policy against those fingers.
So Ravi loses a big chunk of his cheek. How do they fix that? You can't just walk around with a hole in his face.
Reconstruction is key. They bring in a flap.
Like a skin graft.
More complex. A flap brings its own blood supply. They might take a section of muscle and skin from his chest. The pectoralis major flap is a workhorse rotated up and patch the hole in the cheek. It's like patching a tire, but with living tissue.
Incredible. But here's the part that was the real wait why moment for me. Ravi's lymph nodes were N0. They felt normal. But the surgeon still decided to slice open his neck and remove them anyway. An elective neck dissection.
This is one of the biggest debates in the history of head and neck surgery. Why operate on a healthy-looking neck?
Exactly. If it ain't broke, don't fix it. But they did.
They did, because of something called occult metastasis.
Hidden cancer.
Precisely.
No.
The statistics tell us that in T2 buccal cancers, even if the neck feels absolutely perfect, there is a 15 to 20% chance that microscopic cancer clusters are already sitting in those lymph nodes.
So it's a gamble. If you leave the neck alone, you're rolling a dice where 1 in 5 times the patient has cancer left behind that you can't see or feel.
And if that cancer grows and reveals itself later, the survival rate drops by half. You lose your best chance to cure him. So the surgeon makes a preemptive strike. They clear out the main drainage basins for the cheek, just to be sure.
It's a statistical defense. You're paying a high price upfront for a bigger surgery to avoid a catastrophic cost later.
That's it. And the pathology report from those nodes tells us the truth. If they're clean, great. If we find microscopic cells, then we know we saved his life, and we add radiation therapy to mop up anything that might be left.
It's a grueling road. We traced Ravi from a tiny, painless ulcer to this massive reconstruction and neck surgery.
It just highlights why you have to respect this disease. It doesn't play fair.
So if we're pulling the actionable nuggets out of this deep dive,
Yeah.
for me, the biggest takeaway is the silence of those early symptoms.
Absolutely. Do not wait for pain. If you have a sore in your mouth, a white patch, a red patch, and it's not gone in 2 weeks, get it checked. The wait-and-see approach is so dangerous here.
And looking for that rolled edge.
The rolled edge, the hardness. And if you are a smoker or a chewer, you need to understand the chemistry you're running in your own body.
That solvent effect, alcohol plus tobacco, equals a superhighway for carcinogens.
And copper equals leather. It's a recipe for disaster.
I want to end on that concept of field cancerization again. I just can't get it out of my head. The course described the tissue as condemned.
It's a heavy term, but it's accurate.
It changes how we think about healing, doesn't it?
Mhm.
We like to think of medicine as fixing a broken part. You replace it, the machine works again. But here, the machine itself, the whole field, has been fundamentally altered.
It has. The genetic memory of those 40 years of smoking remains in the cells, even after you cut the tumor out.
So the cure isn't a finish line. It's really a new state of being. It's about managing a permanently altered landscape. We aren't just weeding the garden, we're trying to grow crops in salted earth.
That is the reality. But knowing that is powerful. It means vigilance. It means we don't get complacent.
A heavy lesson, but a vital one. Thanks for walking us through the logic of Ravi's case.
Always a pleasure to decode the mystery.
And to you listening, thanks for diving deep with us. Check your mouth, stay curious, and we'll see you on the next one.